Hi guys, it's time for an April update. I have a few things. So lately I've been hearing concerns about ED efficiency and safety, and sometimes our job is getting harder, really is harder than it should be. And so one of the places that I wanted to start looking at as a group is decreasing physician interruptions from staff. And the second thing is I want studies and tests to hopefully be done in a more timely manner. So there's a lot of behind the scenes things where we're looking at radiology efficiency and lab efficiency. But one of the things that our department has control over is how the physician's time is utilized, really. And often we're getting interrupted even as an entire room, where someone comes into the doc box and is like, who has patient in bed 5? And then they proceed to be like the fourth one in line to be asking us the same question that we've already been asked about pain meds or whatever. What are we doing with this patient? And so one of the things that I wanted to try to do was to put out kind of a campaign to the staff of decreasing physician interruptions. And the suggestion that we are putting out there, and the thing that we would like to educate to, is to, when someone has a question, whether it be a tech or a float nurse, or somebody was grabbed by a hallway patient, instead of coming straight to the doc, what are we doing with this patient? Going to the primary nurse and being like, what is the plan with this patient? Because then the primary nurse can look at their screen and be like, well, they're pending a CT and a urine still, so when we have those back, we'll know. And so hopefully it'll decrease the amount of times that we are being interrupted. So we want anyone with a question about a patient to go first to the primary nurse, or the lead as a backup if the primary is upstairs or whatever. And ask them first, because I think it'll do a couple things. It'll decrease the amount of interruptions directly to us, but it'll also force the primary nurse to go back to the task list and make sure it's getting done, because I think that's sometimes an issue. And so I'm hopeful that that will start to kind of move the dial a little bit. And so one of the things that we've been asked in return is to maybe update the primary nurse, either going to find them and being like, hey, we're taking a pivot and, I got all these labs back and now I got to order a CT, or I got to get this specialist involved or whatever, trying to let them know, whether it be a direct conversation or whether it be maybe putting in the comments section, like, I'm awaiting road test and the specialist and then dispo, or I'm waiting on the albuterol to see if it works, or in kind of updating a little bit more frequently. And so those are the places where I'm hoping to move the dial a little bit on our interruptions and redirecting the staff to get their tasks done so that we can make that disposition. Let me know how that goes. If it's not working, then we'll want to try to shift somewhere else. But I want to start there. So we're pushing out education. I meet with the leads next week, and then hopefully by the end of the month, everyone will be aware that we're trying to decrease interruptions to the docs. And if individuals then by the end of the month are coming despite their education, remind them, like, did you ask the primary nurse first? And so it'll be kind of an individual accountability thing at that point. That kind of moves into the next issue, discharge vital signs. If you're not getting alerted of abnormal vitals upon discharge, the nurses and techs have been the nurses have been extensively educated about this. You should be alerted about abnormal vitals on discharge. If you are not, it's an individual problem, and either the nurse needs feedback directly from you right then, which you have full support to do that, or you need to go to their lead, or you can text Thomas or myself or whoever. But it's an individual issue at that point. Once we've sent out a lot of education, it takes accountability on the individual level. And again, if it's not being done, please let them know or somebody know to be able to address that issue with that person directly. We were sent lead surveys from Bree, and they are compiling feedback from staff and then from docs. Actually, they created a special survey for us to give feedback to the leads. Now, this information actually comes back to Bree completely confidential. There's no identifiers on the information that she gets back. And then from there, it's even further scrubbed into like pie charts and like this many people weren't happy with your communication, or, you know, it's like this percentage of people more. And so it's like very scrubbed data. And then if you have directed comments, they're also going to take those and like really take out any personal anything identifiers in that that might come across like on June 17th you did X, Y, and Z, because then it's too identifiable. But if you have really specific things and they start seeing a pattern, it becomes much more meaningful for them doing these lead surveys and giving really good feedback. So please, I need all of our group to fill out those lead surveys because I think it will also help move the dial. Because if we aren't doing that and we're not giving our input, the department is not going to go in a direction that we want it to. And so this is one of the best ways to start moving that dial, hopefully, and really working in a place that we want to be working in because it's efficient and well run with great staff. Holter monitors are available now. They're called ePatch. There's actually not an order that you have to put in. You just have to ask the tech or the nurse to set them up with the kit. And it's actually a really cool device that they can put on at home. It's like super straightforward. The little device thing fits in this holder that's like held on by Tegaderm, and they're sent with like 3 different holders so that if one falls off in the shower or, you know, while they're moving around or whatever, they have additional ones. And then they put it in a little like pre-addressed envelope and send it back to the company. And then the company sends any concerning results directly to cardiology. And so they field it from there. These can be put on anywhere between 3 and 14 days. So you can just specify the amount of days that they're supposed to wear it in your notes. So like, I'm going to have them put on an ePatch for 14 days. And then the billing all happens separate from the ED. We're actually not billing for it from the ED, but if it helps your disposition, if it keeps them out of the hospital, then great. They'll stick it on. And if there's something concerning, then the cardiologist just gets called directly, not through the ED. So those are kind of cool. Let me know how that's going. And I asked Dr. Davidson, like, hey, how long would you put these on? And she was like, 14 days. So I think the only disadvantage of that is that each day gets billed, like each incremental time gets billed more. So, you know, if you think that they're having tons of little arrhythmias that you might be able to capture in a lesser time than 14 days, great. But otherwise you can do it for 14 days. We were asked by the radiologists if we could minimize the CT angios of the head and neck in non-stroke patients. So like they had a rule out subarachnoid that they've been seeing more and more. And I think it's become kind of our knee jerk to do CT angio head and neck, whereas it probably most of the time isn't necessary to do the neck. I mean, if you think it is and they had that like terrible neck pain that now they're having stroke-like symptoms or whatever, include it, that's fine, because it, you know, if you're looking for their dissection or whatever. But if it's like a simple, you know, subarachnoid history and whatnot, if you don't really think you need the neck, just try not to order it, because it's hundreds of images less that they have to look through. It takes a lot less time for them to send it to direct rad and all that, so it hopefully will help our efficiency a little bit there. You can cancel orders, or excuse me, prescriptions now that you've sent to outside pharmacies. You're able to just go and click on the order and then put cancel DC instead of having to call the pharmacy. They actually get canceled through that system, with the caveat that any Adventist health pharmacies, so the Greenleaf Pharmacy and the Stockton Road Pharmacy, they don't have that functionality. So if you sent it there, you've got to call their pharmacy to cancel it, our pharmacy to cancel it. But any other pharmacies, Rite Aid, CVS, you should just be able to cancel it and it automatically goes into their system. We have found out that normal saline boluses that are ordered to be given over less than 31 minutes can't be billed for. So if you have a normal saline bolus over 30 minutes, it can't be billed. If it's 31 minutes, it can be. So Jeremy's going to try to help all of us change our order sets, but it's going to be like a huge project because we all have various fluid boluses and a bunch of different order sets. So if you catch that, try to change it to 31 minutes because they're losing like hundreds of thousands of dollars a year just because of that little glitch. Sepsis. If you'll make sure you're still responding to Steph Dana on any sepsis documentation issues, our biggest fallout problem is still with fluids. And so if I'm going to include in the email accompanying this the dot phrases that give you fluid exemptions or count EMS fluids and whatnot. Also, the nurses are getting pushed to them that if they have too low blood pressures where the MAP is less than 65 or the SBP is less than 90, that they're to let us know, because I know there have been some times where the patient's languishing and they're not catching it. Again, that's an education that's gone out. It will continue to go out, but also feel empowered to give direct feedback or to the lead as soon as possible, because it's most helpful if it's happening real time. PHI now has 2 of their units have high flow nasal cannula. It's only 4 years too late, but it's still yay. When we are ordering radiology studies, any radiology study, please in the comments section be as specific as possible about the symptoms, the onset, any history that might be relevant, like cancer or prior surgeries, or like on an extremity, as descriptive as you could be about where the maximal point of pain is. There are studies in radiology literature that shows that their accuracy of reads goes up exponentially if they get a good history. So our job is to supply them with as much information as we can so that they can interpret it with the most accuracy possible. Don't forget, our incentive metrics are CT angios for PE being utilized appropriately, using the stroke order sets for ischemic and hemorrhagic. So all of your stroke alerts, please use the order set, even if it's kind of after the fact. Put in the order set because it has nursing and other orders that should also be happening. And we are, again, it's an incentive metric for us. Patient satisfaction is still on the list of that. And then sepsis bundle compliance. So again, responding to your documentation, and don't forget the fluid exceptions. And then I'll put in a reminder of the CT angio protocol that was suggested. And I only heard some questions from Alex a number of months ago when I sent it out, but otherwise I didn't hear any dissent. So I'm going to say that's what we should be doing as a group, unless you guys want to say otherwise, but let me know. And then I think that's all I got. I want us to be working in a really excellent place, and I find that the departments that run really well are the ones in which the physicians are very active and involved, and they expect accountability from everyone that's there, from each other and from staff. And so I'm hopeful that we can move the dial on this, and I'm trying to start with simple things to kind of get an overall cultural shift. If you have any other ideas, I want to know them. And so we are planning on meeting to talk about this, and then to talk about shifts, and if we should change those up, the times up a little bit. We are going to meet on April 19th at 1 p.m. Where we have Stephanie. Sorry, my dog just went crazy. So Stephanie and Lockwood are working, so I'm hopeful that the rest of us meet and make a plan together. I'd like you to come with any concerns you have and potential solutions that we can have. And then otherwise, so April 19th, mark it on your calendar, be there at 1 o'clock. And we get to celebrate Levi's birthday, so don't miss out.